This is Dr. Charles Annunziata with Pro Credits. This excerpt from our seminar, Cervicogenic Headaches, Diagnosis and Treatment, will explain the neurology upon how a cervical pathology such as a subluxation or muscular insult can cause the experience of a headache known as a cervicogenic headache. Enjoy.
The diagnostic criteria of a cervicogenic headache. The diagnosis for a cervicogenic headache had to be first and foremost symptom of a headache accompanied by one or more of the following criteria: pain precipitated by neck movement or sustained neck posture, neck muscle tenderness, abnormal neck posture, decreased range of motion of the cervical spine, clinical, laboratory, and/or imaging evidence of a disorder or lesion within the cervical spine or soft tissues of the neck known to be or generally accepted as a valid cause of headache. The upcoming section of the seminar will discuss and investigate the physiology of the cervicogenic headache. The cervicogenic headache pathophysiology and source of pain have been debated, but the pain is likely referred from one or more of the following structures in the neck: muscular, neurogenic, osseous, articular, or vascular. So how can a headache be caused by pathologies of the cervical spine? Well, the trigeminal cervical nucleus helps to explain that. If you look here at the picture, we have the midbrain, the pons. This upper area here is known as the medulla oblongata, and then below that, this area right here is the upper spinal cord of the cervical spine. Now, the trigeminal cervical nucleus is a physiological convergence of the sensory afferents of the trigeminal nerve and the sensory afferents of C1, C2, and C3. This allows cervical pathology to refer to the head through the sharing of a common convergence in the trigeminocervical nucleus, which is this orange band right here, with these little circles known as the nuclei, and the trigeminothalamic tract, which is the tract that takes the information from this nucleus and sends it up to the brain as sensory information. Thus, any nociceptive stimulus from C1, C2, or C3 can cause pain in the head. So let's look at this a little bit closer. So the trigeminal nerve, which we know is sensory, and it has sensory information from the face and the head, so any kind of pain in the face and the head is going to be felt through the trigeminal nerve. Well, the trigeminal nerve ultimately travels up to the brain. However, it takes a very curious road. It comes in at the pons, it enters the brain at the pons, and then it immediately descends into the medulla oblongata and the upper cervical spinal cord. It synapses on this nucleus known as the trigeminal cervical nucleus, and you can see it synapses there, all these little nuclei. Well, not only does it synapse on that nuclei, how the C1, C2, and C3 spinal nerves come into the spinal cord, and they synapse on that nuclei as well. So if you have a pathology from the upper cervical spine, C1, C2, or C3, that information, let's say it's nociception, will come into the cord. It'll synapse in the same areas on the trigeminocervical nucleus as the trigeminal nerve is synapsing. Therefore, these two signals will converge on the trigeminocervical nucleus and then be carried up to the brain on the trigeminothalamic tract as one sensory feeling, which means that the brain cannot dilute or understand if pain is coming from the trigeminal nerve or from C1, C2, and C3. So therefore, any nociception coming in from C1, C2, and C3 will travel up to the brain as a facial or head type of pain if it synapses with the trigeminal nerve. This is an explanation of how cervical spine pathologies, it could be a subluxation, it could be a trigger point in a cervical musculature. Any of those types of structures or pathologies can, through this trigeminal cervical nucleus and trigeminal thalamic tract be referred up to the brain and experienced as head or face pain. So let's discuss how nociceptive input, let's say from C1, C2, or C3, can increase in times of a subluxation. Well, it's important for us to know that decreased mechanoreception causes increased nociception. A healthy joint is constantly sending mechanoreceptive signals into the spinal cord. When a joint becomes fixated or subluxated, it decreases its mechanoreception into the cord, which results in an increase in nociception due to the fact that the fast mechanoreceptors were blocking the nociceptors transmitting the pain. So when a subluxation of C1, C2, or C3 blocks the transmission of the mechanoreceptors coming in, it increases the transmission of the nociceptors going into that trigeminal cervical nucleus that we saw on the previous slide. We know that the trigeminal cervical nucleus has a convergence of C1, C2, C3 along with the trigeminal nerve. So therefore, a subluxation of C1, C2, or C3 can lead to pain in the head and face due to the sensory input from the trigeminal nerve, as we saw on the previous slide. So as you can see, mechanoreceptor input is of vital importance to modulating pain. So what happens if we have an imbalance in this mechanoreceptor input? That is known as disafferentation. This refers to an imbalance in afferent input such that there is an increase in nociceptor input and a reduction in mechanoreceptor input. So think of it like this. When we have an increase in mechanoreception input, we have a decrease in nociception input. So an increase in mechanoreception would cause modulation of pain. However, when we have a decrease in mechanoreceptor input, such as a subluxation, that will result in an increase in nociception. That is why many times when a patient has a fixated or subluxated joint in their spine, they have pain associated with that area or with that joint as well. Now, mechanoreceptor information reaches numerous centers in the CNS. So when we have disafferentation, we could have other issues. So consequently, a reduction in mechanoreceptor input caused by joint complex dysfunction or the subluxation has the potential to promote numerous symptoms that can mimic lesions of the vestibular nuclei, the cerebellum, the cerebral cortex, and the basal ganglia. This is why the subluxation could be more than just a musculoskeletal presentation. The idea that increased mechanoreception decreases nociception and vice versa is apparent when looking at joint dysfunction physiology. Peterson stated that joint dysfunction, which could mean a subluxation, induces persistent nociceptive input and altered proprioceptive input. Proprioceptive input is also known as mechanoreception. Hushman showed that restricted joint mobility, such as a joint fixation, results in decreased firing of A beta fibers. Remember, A beta fibers are associated with mechanoreceptors, and increased firing of A delta and C fibers, which, as we know, are the fibers that carry the perception of pain or nociception. And Henderson proposed that the adjustment, or the chiropractic adjustment, normalizes afferent input into the nervous system.
I hope this explained how a cervical subluxation can cause a cervicogenic headache. To find out how to treat this, please go to procreditsce.com and take the Cervicogenic course, or you may take one of over 50 other courses designed to help the chiropractic profession. Again, procreditsce.com. Thank you.